few housekeeping items. But first, just welcome you all for taking the time out of your busy schedules to be here. We really appreciate having the opportunity to discuss how physician assistants can help, improve healthcare access in the province. Next slide. Now we have a pretty lengthy slide deck here. We're going to hear from CAPA, the Canadian Association of Physician Assistants. We're going to hear from the University of Saskatchewan, as well as the College of Physicians and Surgeons of Saskatchewan and the Saskatchewan Health Authority. So we ask that you refrain from asking any questions until the end of the presentation. But then afterwards, there's going to be a Q&A period, and we'll open up the floor and allow attendees to ask questions using the Zoom chat or raise your hand function. So next slide. So my name is Christy Carente. Despite what my name here, I'll just change it so that you can see. Despite what my name had previously said, my name is Christy Carente. I'm the Director of Advocacy and Communications from the Canadian Association of Physician Assistants. And I'm just going to kick things off here today and talk a little bit about the PA landscape. And we thought what would be, something that you'd be interested in learning about, and that's the status of the PA profession throughout Canada. So we're going to start off with regulation. So right now, PAs are regulated Alberta, Manitoba, New Brunswick, Nova Scotia, Saskatchewan, as well as Prince Edward Island. And we have Ontario that will be enacting regulation in April of this year. Newfoundland and Labrador, they've invested in a PA pilot project, and they're currently in the process. They've drafted regulations, so that's currently moving through their legislature as we speak. Quebec has a pilot project in Region 18 for the Cree Board of Health and Social Services in James Bay, and the college there is also in the early stages of regulating the profession. At the end of 2023, the Yukon government unanimously approved a motion for PAs to practice in the territory. So it's in the very early stages, but we're very excited to see that there is interest and support up in the territory. And British Columbia, they announced that PAs could practice in the fall of 2023. And so the college there, they drafted bylaws to allow PAs to practice in the province as well. And so we're very excited that PAs, last year was a big year for PAs because now PAs can practice coast to coast. And as you'll note here at the bottom, all the provincial colleges of physicians and surgeons, they regulate PAs. Next slide. This is an important slide. I imagine there are a lot of, questions about education. There are currently 5 university programs for PA training in Canada. And this dates back to 2008. So we have McMaster, University of Manitoba, and University of Toronto. They've been established for some time now. And Dalhousie University, they launched in January of 2024, followed by the University of Calgary in the fall of 2024 as well. So the programs, they're very highly competitive. They're very in demand. There are over 2,500 applicants, maybe even more, close to 3,000 per year for a combined total of 183 seats. And so it's very fortunate that Saskatchewan will be launching their program in September because we have a bit of a supply and demand issue. We need more PAs trained in the country. And then we have other institutions that are exploring establishing programs as well. So University of Ottawa is looking at a bilingual program, Western Queens, Laval, UBC, and whatnot. And the program is fairly intensive. The program's aligned with the medical model to lay the foundation for that collaborative working relationship with physicians. All the programs are accredited. They extend over 24 months. And when you're done the 48-week training program, you have a certification exam. And next slide. And with that, I'm going to pass it over to CAPA's director in Saskatchewan, Todd Bryden.
Hi, good evening and welcome everyone. As stated, my name is Todd Bryden. I've been a practicing PA for the past 14 years. So a little bit about what a PA is an advanced healthcare professional that work as physician extenders. We work under the scope of a supervising physician, which means that anything that a supervisor remains competent and confident to do, they can delegate down to the PA. Negotiated autonomy, it takes some time to build that, and some faster than others depending on the experience level, but it can take directions or sometimes simple questions to the supervising physician. We work collaboratively with healthcare professionals and teams to deliver enhanced care for the care of patients. And PA is presently employed in all aspects of healthcare across Canada. So if there's a healthcare specialty or subspecialty, you can usually find a PA in one of the province working in there. And we, as per the PAs do that, all of those things on the bottom, the same as most clinicians, we do all of those things and sometimes a little bit more depending on our past training or other training that we receive. Next slide. Our supervisor relationships, they're pivotal. We have to have a good relationship with our supervisors. We always work in a framework, although that framework can be, I can be sitting here in Garden Hill where I'm at right now, and my supervisor can be in Winnipeg or anywhere in the province as long as I can reach them by phone call. But that is that negotiated autonomy. The nature of the relationship and trust is dependent on the physician's experience with the PA, which grows over time and exposure to the PA's practice and how the supervising physician wants the PA to practice. Each of us require a contract to supervision and our practice descriptions documenting in both provinces. While I work in Manitoba, it's very mirrored to the system that is in place in Saskatchewan. And our clinical work we perform, the expectations of the PA and the location of our practices are all included in there. Right now, I do believe I have 12 different communities that I can work in with approximately 40 alternate supervisors in that range, working with the group that I work with right now. So next slide. We all complete our Canadian Physician Assistant Certification examination to obtain our national license as a CCPA. The Physician Assistant Certification Council is independent of CAPA. They administer the exam and are a different board. The US license obtained from NCCPA, they are recognized in Canada as well, and they are certified or PAC. We all must maintain and renew our CAPA membership as yearly. We also fall under the Physicians and Surgeons of Canada, Royal College, and we use their MOC for our recertification of our CPD. And we require 250 credits over the 5 years, and we have to have 25 annually, which is mainly the same for everybody else who falls under the Royal College. Next slide. In Saskatchewan, they allocated funding for 12 PA positions originally. They introduced legislative change to allow PAs to practice, which was great news. Government passed the legislation to regulate PAs under the College of Physicians and Surgeons of Saskatchewan, which fell in line with all of the other provinces. And I had great conversations with all of those bodies. And the government invested in the master's program that you'll hear about shortly, as well as Saskatchewan Health Authority and Saskatchewan Healthcare Recruitment Agency, currently recruiting for the 12 positions and hopefully more in the future. Next slide. And at that point, I will turn it over to Dr. Domes with improving healthcare access.
Thanks a bunch, Todd, and thanks to Kappa and our affiliates here for having the impasse program present tonight. Great to see a really large group here. First week back for some of us to work. I really appreciate everyone coming, and really it's an exciting time to be in Saskatchewan with this change, and really happy to be part of it as well. So I'm going to talk a little bit about our impasse program that has been mentioned by Christy is to launch later this fall. Next slide. As we begin here, I also wanted to acknowledge our lands and acknowledge our treaties. So we are all treaty people, and wanted to acknowledge here in Saskatoon, we're on Treaty 6 territory. I know people are coming from all the treaty territories here in the West, including in Manitoba. Nice to see Dr. Goulet with us as well, coming from Manitoba. And of course, the homeland of the Métis. Without the strong partnerships we have with our Indigenous partners, patients, and communities, we would not be able to do the work we're doing today. And I really wanted to pay respect to our First Nation ancestors and Métis ancestors and reaffirm our relationship with one another in both truth and reconciliation. Next slide. This was alluded to, but it's sort of the impetus to where we are now and what sort of spearheaded the master's program. So, of course, everyone working in healthcare knows, not just here in Saskatchewan, but throughout the country, is we are in a human health resource crunch. There's a supply-demand problem, lots of patients, not enough providers, leading to issues in terms of access and quality of care. And so one of the strategies, of course, is to look at how do we increase the recruitment and how do we retain and train and give incentives for us to keep our human health resources here in the province. And so as we were bringing in PAs from a legislative point of view, the province, I believe, made a really smart decision in also wanting to bring forward a PA program. So that was the impetus to bringing forward our program in a fairly short time frame. Next slide. And because it's a brand new program and because it's a brand new profession in the province, it really gives us an opportunity to do things a little differently than what we've done before. You know, traditionally we have education, our human resources, and our healthcare delivery somewhat in different silos and pots, where this program, along with, of course, the partners and our affiliates, will hopefully be able to create a new reality where we really integrate in the educational piece with the human health resource piece and the healthcare delivery piece, so that the impasse program is integrated into everything that's done. So it can help with some of that human health resource need. It can provide, obviously, the education piece that we need, and with the whole goal of course, improving healthcare delivery and quality of care for patients. Next slide. We had a really great visioning meeting with about 40 to 50 stakeholders back in October, where we went through our vision, our mission, and our beliefs as a collective. And this is what came to be when we crystallized everything. And so I thought I would read these out, because I think with these, it gives us that light that we need from our program perspective going forward. So I'll start with our vision. So our vision of this program, again, this is collective, is to educate, equip, and empower physician assistants to be a catalyst for system change through clinical excellence, innovation, research, advocacy, and inclusive partnerships and collaborations. Together, we will advance equitable and community-centered healthcare to Indigenous, remote, rural, and urban communities across Saskatchewan. So again, it's a very ambitious vision, but it's a vision that we see is really, really something we can obtain in the future. Our mission is to provide that comprehensive educational program that trains physician assistants to excel in diverse clinical settings, think innovatively to improve healthcare delivery, champion collaborative team-based care, and provide compassionate and empathetic care to all. And our beliefs of our program is we believe in improving the health of all through social accountability, health equity, and Indigenous health advocacy. We believe that addressing health disparities requires listening, exposing and removing barriers, improving access to high quality care by a trusted healthcare team. So those are our mission, vision, and belief statements. And when we look at the roadmap of our program, so as mentioned, it's a fairly intensive 96-week, 2-year full-time program. It's putting a lot into a fairly short period of time, so it is intensive. It's at the master's level. So in terms of getting into the program, it requires a 4-year bachelor's degree in any discipline, but we do have prerequisites in anatomy, physiology, and Indigenous studies. This program also has a little bit more of a rigorous research requirement because it is at the master's level. In terms of year one, we'll go through this in the next slide, but it has 4 main courses that look at the foundations of medicine. There's a research course, clinical skills course, and then a professional practice course. In these courses, we hope to use innovative teaching methods and strategies so we can really ensure that our learners are learning state-of-the-art care using innovation and educational excellence. And then also we want to expose the learners as much as possible early on to the healthcare system and to healthcare teams and clinical exposure. They'll also start their research project in year 1. And then year 2 is that clinical year. Our expectations in year 1 is that it's going to be delivered in Saskatoon, but in year 2, we want that education to be distributed. There's such rich learning in obviously healthcare outside of the urban centers. So we want to expose the learners to those rich environments. And again, I think it's also important to expose them to rural Saskatchewan as well, because there's such a huge need for PAs in those environments. And then the research will continue, and a capstone project will be presented at the end of the program. And when we look at the highlights here, this is just sort of a listing of the courses. But really, again, our main goal is to get that collaborative, team-based care, train the future PAs to be leaders, to be empathetic, to use technology appropriately, and to really shine as a new profession in the province. Because obviously, you know, as was mentioned, it's a very challenging and competitive environment to get physician assistants right now. There's just not enough trained and not enough in the country. So we really are going to focus on training our own with the hope that we train them to keep them here. Next slide. And certainly we can't do this alone. This is going to be a group effort to bring on this transformative change. And so there's a lot of opportunities for faculty to get involved in our program. There's going to be actually an email coming out very shortly that's going to a request of interest for people who want to get involved in the program from a more leadership perspective, but also from a teaching and program delivery perspective. We'd love to hear your thoughts. And I've already received emails from numerous people as well, being very enthusiastic and excited about this coming. So please contact us at mpass@usask.ca if you want to learn more or if you want to be part of our program. Thank you. And this is just a quote that encapsulates sort of why we're all here, right? I do truly believe that there's immense power when a group of people like us with similar interests, which really is how do we improve our patient care and the healthcare system, when we get together and we work towards that goal. Thank you.
All right. Well, I hope everyone can hear me. My name's Deborah Wright, and I'm joining you from the College of Physicians and Surgeons in Saskatchewan. Over the next 10 minutes, I'm going to do my best to provide you guys with some details about physician assistants and practice requirements in Saskatchewan. And I believe also with me is our registrar of the college, Dr. Stoneham, as well. So he may, over the course of the presentation, also add where he sees fit. All right, so earlier within the presentation, and just to kind of recap, physician assistants are classified as physician extenders. They're not physicians. Physician assistants must be supervised at all times and by a physician who is licensed to practice medicine in Saskatchewan. And a physician assistant cannot practice independently and can never serve as the most responsible physician. And these are sort of the guiding principles around the regulation and what you'll hear in terms of some of the requirements. So bylaw next slide, thanks. Bylaw 2.13 outlines the requirements for a physician assistant to be registered and licensed in Saskatchewan. So similar to other forms of licensure in Saskatchewan, physician assistants where are we at here? Yeah, next slide. Thanks. Physician assistants must demonstrate English language proficiency, provide evidence of good character, and must be in good standing. They must also have currency or recency of practice and must demonstrate that they have completed the required training and hold certification as a physician assistant, either in Canada or the United States. In order to enter into practice, physician assistants must demonstrate that they hold the liability or malpractice insurance of a minimum $2 million per occurrence, as well as have a primary supervisor identified and have a practice description and a contract of supervision signed. And we're going to talk a little bit more about that. So next slide. Yeah, good. So in Saskatchewan, a physician assistant's practice is bound by three things. So first, it's the contract of supervision, which outlines the terms and conditions for performing the duties described in the practice description. So second, the practice description outlines the duties and services and the procedures that the physician assistant will be expected to deliver. And then the third component is the scope of practice of the supervising physician and what they're authorized to practice. Both the contract of supervision and the practice description must be approved by the registrar before practice can be initiated by the physician assistant. I also thought I would add just a comment here about physician assistants and the practice environment. So there are no limitations from the regulatory or bylaw perspective on where a physician assistant can practice, as long as that supervisor is identified, a contract of supervision, and a practice description is in place, and the physician assistant has been appropriately trained to what the practice environment demands. So a physician assistant can practice in a primary healthcare clinic, a community clinic, a surgical or medical ward, or emergency department. The issues of things like payment or billing of that physician assistant are things that the CPSS would not be in a position to answer, as it's not part of the mandate or requirements around regulation. We'll go to next slide. So one thing that we wanted to highlight that's contained within a practice description is something called the level of competence. So the practice description will ask that the level of competence of a physician assistant be identified. The levels are graduated and are expected to change over time. So because a physician assistant's training is broad and generalized, physician assistants must be oriented and trained to the scope of the physician's duties and services. So in those early days, a physician assistant will likely be rated as a level 1, where there's a high degree of oversight needed to ensure that a physician has the adequate knowledge and skill. Over time, and as the physician supervisor and physician assistant builds greater comfort, confidence, knowledge with each other and the work, the rating will increase. So kind of a rule of thumb would be level 1 is similar to what would be required to supervise a medical student, and level 5 might reflect more of what's required for a senior resident. And we'll go to next slide. So this slide we put together just to kind of illustrate how the degree of oversight of a physician assistant will change over time, and the timing of how that changes will depend depending on that physician assistant and that supervisor. But in the early days, a physician supervisor might be working side by side with that physician assistant while assessing the knowledge and the skills and comfort with some of the key tasks. Over some time, that supervisor might start to feel more comfortable and perhaps start a particular task and then leave that physician assistant to complete and report back the outcome of that task. With more time and as more comfort and confidence builds, a supervisor might be located down the hall, might be reviewing paperwork or meeting with another patient while that physician assistant is performing an assigned task that the physician supervisor is comfortable and confident that that physician assistant can do. And this will continue as the comfort and confidence builds, the level of competence will change and increase. We also thought we'd kind of highlight that a physician assistant who maybe has worked for 7 years with an internal medicine, but then maybe accepts a position in orthopedics, they would start back at square one. So they'd have a new practice description. It would need to be prepared, and the level of competence would likely again be low because the level of supervision would need to be high, as that physician assistant would need to be oriented and trained to the new clinical area. So that's how that kind of cycle would continue if there's a change in area of practice. Next slide. So throughout the supervision relationship, the physician supervisor is responsible at all times for the actions and decisions of the physician assistant. The supervising physician remains the most responsible physician with all of the responsibility and liability that entails. The physician who's supervising is not required to obtain more or different malpractice insurance as a result of supervising a physician assistant. The supervising physician can delegate any responsibility that falls within their own authorized scope of practice as long as the physician assistant has been appropriately oriented and trained to deliver that responsibility.
I'll use my kappa.
In terms of department group practice, a physician assistant will work to the scope of the named primary supervisor and not to the group of physicians within that group practice or department. And in these early days, it's likely that we won't authorize a physician assistant to work under 2 contracts of supervision or 2 practice descriptions or with 2 primary supervisors. This is a new role for our health system, and I think we feel we need to learn to walk before we can run. So focusing on 1 primary supervisor per physician assistant in an environment is probably an important early safeguard. And then lastly, physician assistants are currently prohibited from prescribing controlled drugs and narcotics in Saskatchewan. We'll go next slide. Okay. So in addition to providing that kind of clinical oversight and training, the supervising physician is also responsible for preparing and submitting reports to the college. So in the first 3 months, while the practice responsibilities are being trained and observed, we'll ask the primary supervisors are submitting reports monthly to the CPSS. After those first 3 months, reporting will transition to every 3 months. So you would report at 6 months, 9 months, and 12 months in that first year. Going into year 2, the supervisor will prepare reports every 6 months. So you would submit month 18 and month 24. And then after that, we move to annual reporting because it is at this point we expect that the physician assistant practice has stabilized. We also kind of within the practice description and contract of supervision outline that if a primary supervisor is going to be away for longer than a 2-week period, we'd ask that we be notified in case we need to be engaging with that supervisor on a particular matter. And as outlined in the bylaw, a physician cannot supervise more than 3 physician assistants at any one time unless specifically authorized by the registrar. Next slide. Or I guess we're at the next slide. Lastly, the supervision report is based on the CanMed's competencies. And so while this screenshot probably makes it look like the report is long, it's simply due to the amount of space we've provided for each of the CanMed domains. Where possible, we have included helpful prompts for the supervisor to reflect on or consider when completing the report. We've created check boxes to quickly and easily signal performance that's being observed. So whether it's meeting the standard, exceeding the standard, maybe not observing yet. We've also included a space for a supervising physician to update the level of competence if it's progressed over the period of supervision. And then lastly, there's a space for signatures, which also includes the physician assistant sign off. And the hope is that the reports are being reviewed and discussed with the physician assistant. So while the primary supervisor is responsible for submitting the report, input for the report can come from all other supervisors or fellow colleagues who may have had interactions or side-by-side experience with that physician assistant. And at the end, I just say the reporting responsibilities are not intended to be time-consuming or administratively burdensome. It's rather to confirm the awareness and alignment of supervision requirements and the supervisory relationship. Reports in the early days might take a little longer, but over time, it's not anticipated that these reports would take more than 30 minutes to complete. All right, I'll leave you guys there, and we can move on to the next presenter.
Thanks, Deborah. Can everyone hear me okay? I got a head nod. All right. So Good evening. My name is Jessica Piche, and I'm joining from the Saskatchewan Health Authority as the Workforce Planning and Employment Strategies Manager. I'm one of the individuals who supports the initiative to recruit PAs into our health system. Just wanted to start by saying thank you so much, Trustin, for our land acknowledgement and the content shared this evening from all of my partners today. Todd spoke a little bit earlier about the investment made by the ministry, so I'm going to talk a little bit more about that as well as the positions that we're looking to recruit into. Next slide. So in October, that investment made by the ministry resulted in $1.3 million in support of 12 physician assistant positions. You'll see a list of opportunities that we have currently posted onto our website on the screen now. And to enhance our recruitment, the Ministry of Health approved posting additional 10 positions in addition to those 12 that we had already positioned in order to offer a greater array of options, including some urban locations as well. These initial postings are really just to allow us to recruit into those processes and start into the recruitment process of identifying candidates, but we acknowledge that there may be need to realign the positions based on either applicant experience or preferences. So that's been a major focus as we continue to recruit into those jobs. Next slide. In collaboration with our partners in the health system, we do have a multifaceted advertising strategy that's been developed. We're also working very actively to develop our talent pool and continue to expand our reach through word of mouth in the physician assistant community. A number of these places, we're starting to see that our interactions and expressions on those ads are continuing to expand and grow. But we're also building more material, lots of really great information shared from my partners this evening, but all of that information together kind of being presented to really establish the impact that this classification can have on the health system. One of the great tools that I love that's really pulling together more information is the career profile. So if you haven't had a chance to take a peek at that yet, it is on our SHA website. But partners with USask and talking about some of the joint positions that we've been offering with them as well. For me.
Which comes back to myself to introduce our speakers tonight. First off is myself. It says 35, it was 22 years of military experience, 14 years of clinical experience as a Canadian certified physician assistant. I've worked on for 7 years HMCS ships as well as in military clinics. Then followed for 5.5 years at the University or Department of Surgery, section of urology at Winnipeg Regional Health Authority. And now I do fly-in medicine with Ongamazin Health Services and Northern Manitoba flying communities where no roads. So it's interesting medicine up here. My counterpart and alternate director for Saskatchewan is Ashley Milham. He has 35 years of military experience. We graduated together, so 14 years as a Canadian certified physician assistant. Worked with the Special Forces Operations Forces as well as primary care clinic supervisor. In his final 2 years and has been a program director for the PA program in its final, before it closed down. And he also currently in urgent care medicine at a diamond mine in a remote region of Northwest Territories. Next slide, please. And I'm also pleased to introduce one of my alternate supervisors, Dr. Sarah Goulet, who's the Associate Dean of Admissions for Max Rady College of Medicine at the University of Manitoba. She graduated from the University of Manitoba Family Medicine residency in 2007. She is our senior lead for our fly-in program with Ongamazin Health Services, and she provides leadership and support to the fly-in physicians and physician assistants. She is currently the primary supervisor for 4 physician assistants, as well as alternate supervisor for over 20 PAs. And with that, we shall go to the next slide and open things up. I know we've had a couple of questions already posted in the chat, so we'll do our best to answer those.
wonder if it would be a good opportunity, Todd, to hear Dr. Goulet's perspective as an MD, physician supervisor of multiple PAs, and what value you see, Sarah, from your perspective in the value that PAs bring forward to the healthcare system and access to care. I know you work obviously in family medicine and also obviously in multiple communities.
Yeah, no, certainly I'm happy to speak to this. I will say, so I work with Todd, obviously, in a very remote part of our province in Island Lake. I have also worked in Nunavut. I don't think I've ever worked in Saskatchewan, so have about 20 years experience working in rural and remote settings. I've also done some work as a house medical officer role in our surgical intensive care unit. I did that for about 8 years. And so that's sort of like supporting the intensivists by us staying in overnight. I don't know if you have house medical officers in your ICU, but we essentially run the ICU at night. And worked as a HMO like role in on a family medicine hospital ward, I'm going to say, at our major tertiary care center, as well as providing that role for our trauma team, who would do like all the trauma and general surgery in the hospital. So worked in quite a few different places. In some of those roles, I also had a chance to interact with physician assistants. So my exposure was on the trauma surgery ward, where like we tried to, obviously it's a huge busy ward, and sometimes I think they were finding the surgeons were so busy trying to do surgery and take care of people and stabilize them that the back end of patient care was challenging to manage. And so they had first of all recruited physician assistants to help with that, who were also sort of ended up supporting a lot of their new residents and doing a lot of the work, including surgical assist and taking care of patients at night, and some of the more acute roles. So that's when they decided to bring in family doctors like me to, after people's acute care needs, to just maintain and take over care. But we still worked really closely with the physician assistants, who often on that ward knew patients better, and like sometimes than the surgeons, who were the ones turning over every week, because physician assistants were the constant. Residents and everybody else were changing, and so we would rely on them to give us background information on the patients that we inherited. So that's how I first found out about physician assistants and had the chance to work with them. I think I wasn't totally understanding of the scope and knew they were helpful at that point. During COVID, we had the opportunity to work with Tara Clark, who's our main physician assistant lead within Algonquin Health Services. And she sort of came in because we had some additional federal funding and started coming to work with us in different communities, mostly to do immunizing and testing for COVID. But as sort of our COVID needs transition down, we still maintain some of our extra federal funding. So we were able to bring her on to work with us in a more clinical setting. Didn't know what that was going to be like. Was probably sort of similar to you, had a lot more questions than answers. And, you know, just as we were talking about, when you switch practice sites, which working in a rural remote setting is very, very different than working in a family medicine clinic in Winnipeg or in some of the emergency departments that she'd been in before. Just had a ton of questions and needed a lot of answers to things, even though she knew sort of the medicine, the practice pattern, referrals, how we get antibiotics here, the types of antibiotics we prescribe, the types of patient care that is needed. How do you transfer a patient on a medevac? Where do they go when you're going to send them? All of those things just found she needed support with, and it was so useful to have her here, especially as sort of we just heard from the college, as we got more comfortable with each other and built a trusting relationship, she was able to sort of pattern her practice to what we do. And we work in a team environment here anyways, and are used to working with multiple team members. So may have been a bit of a easier adaptation for us to have just another member of the team come in. So that experience, I think, helped us all in our team acclimatize to the role of a physician assistant, which was incredibly positive. And since then, Ongomiswin has, I don't know, we have more, I think we have 25, 30 PAs is what we decided. And many of them work regularly. Many, like Tara, work completely. I'm still her primary supervisor. She's right now in a community known as Pangasi, which is across the lake from where I am. She called me when she wants to bounce ideas off of me, just in the same way that I would call a colleague and say, hey, I'm not sure what to do in this case. Like, do you have any ideas, or where do you send somebody for, general ophthalmology now? Because all the ophthalmologists don't want to see kind of general ophthalmology cases anymore in our province. But in general, because we work together so closely, and she worked with us in Garden Hill for about 18 months before she ever went anywhere else. And we worked closely, and she reviewed cases, and we as a team sort of decide, like, how are we generally going to manage diabetes, or how do we generally approach things? So she was a part of all those discussions and helped in more of contributed her knowledge to the situation. And I would say the same thing about Todd, because Todd's been here now for 3 years, that we work more as colleagues now. At first, when Todd came on, he'd come from a urology service at HSC, which has been incredibly helpful for us, and his connections. And, we mentored and went and saw every patient together, and he got advice just like any level 1 PA would, even though despite his years of experience, you'll see, obviously someone like Todd with all his experience progresses through the levels quite quickly. So some of our newer physician assistants who come up, maybe, they stay at a level 1 or 2 the first 5 or 6 times that they're here, depending on what else they do, because we want to make sure that mentorship requires them to consult for every case. After that, usually most of our physician assistants are able to progress to like a level 2, 3, which requires them to just on the phone. I don't have to come and see the patient with them or be in the building. So they can do call more independently, but there's going to be cases that they probably run into gaps in knowledge. Oftentimes it's when ladies come in labor that I get panicked phone calls of, you need to come over here right now. Or sort of major traumas or things that I come and assist with. And then by the time we get up to someone like Todd or Tara's level, Todd sometimes calls me after the whole thing's over and says, hey, FYI, this happened. And this is how I managed it. And this person's so sick that either I need to tell you life flight's coming for them in case you need to get involved, or this is what happened. And could you come and help debrief with all of the chief and counsel and the family? So it does take that relationship, I would say, was really adequately described as just takes a little while to get that comfort level. We now, we use Garden Hill where we are now as a major training site for all of our physician assistants who come into our program. So everybody comes up, we orient them. Typically when they first start coming, like Todd will work with, we have a new physician assistant who just started with us, also has a lot of experience, Kylene. So she's going to work with Todd. Todd's going to review every case with her, probably go see the patients or one of the docs who's here. But as she progresses and comes up in the next few weeks to months, I suspect that she'll be working way more independently and being able to see patients on her own. So Todd's one of our main supervisors now for sort of the new physician assistants and helps to orient and train and mentor, which we find very helpful because it was during the first period of Tara being here, it was a lot of work for us because we didn't really understand the role. We didn't know how to interact. I didn't entirely understand sort of what the contract of supervision was or how to do all these assessments of somebody. So all of those things were new. I would say now they're fine. It's so much more helpful to have our physician assistants, but it was a little bit of work at the beginning. So once there's an investment, I guess, up front, I would say. That's like a 6 to 12 month investment for every probably new physician assistant working in a new clinical environment. And again, that'll be really different if somebody's already working on a surgical ward and they come and join a different surgical ward in the same hospital. Probably that time to build those relationships would be a little shorter. We do and we also have the same rule in Manitoba about a maximum of 3 physician assistants per supervisor. Due to the remoteness and the helpfulness of having physician assistants and the service that we are able to provide because of the number of physician assistants working in our communities has expanded our capacity probably some weeks by 2 times what we're able to do with the docs that we have. Like in other words, I mean, like we would have at least half more of our communities being served, because we usually have physician assistants in 5 or 6 of our communities every week. And if we didn't have PAs, there wouldn't be a doc there. There'd just be somebody on call. So it's made a remarkable difference to our programming and our capacity to be able to we run a walk-in clinic here in Garden Hill because we have physician assistants and because we have that capacity. Whereas before COVID and with only the docs here, we couldn't run a doctor's clinic anymore. We were 6 to 9 months behind in reviewing labs, x-rays, things coming in because the docs were so overwhelmed with the workload. So now we're all caught up in our paperwork every day. Although Todd and I have a mountain of paperwork to help out with after this. We run a walk-in clinic from 4 to 8 every day and try to provide enhanced access, which we would never have been able to do without the physician assistants. And this is working also with nurses and extended care roles. So I would never want to go back to working without physician assistants because of the benefit and the expanded health services that I see the community having access to every day. So I completely think the investment upfront and the learning curve for a doc just trying to figure out how does this whole relationship work is totally worth that time and investment. The one thing I will say is the paperwork. I mean, I can supervise up to 5 PAs and an alternate for obviously quite a number of PAs. So I've a big roster of physician assistants for whom I provide like a report if I'm the alternate to the main primary provider or primary supervisor if they weren't the one working with the physician assistant when they're up. So it's a little different relationship because sometimes the primary supervisor is not always the one working. So we have this system that we can sort of communicate that, and the alternates sometimes fill out the paperwork, send it to the primary supervisor, and then the primary supervisor sends it into the college. Sometimes, well, what we've found, and this was not necessarily from the docs, but the physician assistants themselves actually asked that they do that exercise as a self-reflection. And so now what happens is that, like, Todd's on annual supervision, obviously. So Todd annually, like, thinks about his year kind of similar to what, honestly, like CPSM asks us to do as physicians, which is like reflect on your own practice, decide where your gaps are. You tell us what you think you should work on, and then come back in 12 months and we'll see if you've worked on it and if you think you're any better at it. And I would say that we found that has worked a lot better for our working relationship and building a working relationship, because Todd gives that to me, to the primary supervisor, and we read it and then we can say yay or nay, like, you're being too hard on yourself, or I think actually you have some gaps in this area. Do you want to maybe, like, how can we help you improve that? So I think for us that helped to facilitate the conversation a lot more, and the reporting is way better than when our docs did it, and I don't think the docs knew what to do, and so they felt like they should just sign off and say everything was excellent. And I don't think the exercise was incredibly useful for either party, and especially not for the development of the relationship. So I don't know, it's just something that was a lesson for us that works way better for us now. But otherwise, I think what you're setting up is going to be extremely helpful for your province, and for, you know, increasing and enhancing care. Thank you.
If I can jump in here, I've been monitoring the questions in the chat here. So we've been receiving a lot of questions about NPs can practice independently. So there's some concern about PAs requiring a supervising physician. So Todd, maybe we can clarify that misconception on what supervision means again.
Actually, I was just reading because we had received the email as well as the question in the chat that I see here. So one of the things about the scope of practice and the best way I can do to describe the scope of practice of a nurse practitioner compared to a physician assistant, nurse practitioner scope of practice is very black and white. It's very black and white what they can do, what they can't do. Whereas the physician assistant scope of practice is much more gray. While it's written on paper and you have your scope of practice and from your supervising physician, you are able to do as a physician assistant anything that your supervisor delegates to you who remains competent to perform that skill. So it's for per se, if I'm working with Dr. Domes and I'm working in urology, any of the scopes or anything of the things that he can do, once he feels comfortable that I'm able to perform those and do those competently, he can delegate those sorts of things to me. Whereas a nurse practitioner, a lot of times they don't have that ability to have those skills delegated to them. Their scope of practice prevents them from doing that. I've worked with nurse practitioners in the Canadian military. I've worked with them across Manitoba, and a lot of them say the same things, that some of the specialties, while we work in primary care and acute care very similarly, there are still some differences, which include a nurse practitioner can monitor an advanced ATLS course, right? But they never get the qualification like a PA does. So the PA can actually be a participant on the course. So there's some other differences there when you're talking about emerge, primary care, acute care, and those sorts of things. And then there was the question about if it's fiscally benefit, which I'll turn over to Dr. Domes because he was going to make comment on the compensation report that actually stated those things.
Yeah, thanks, Todd. I think our healthcare system's in need of so many providers, and I think that the thing is that we need is team-based care and collaborative care, right, for the patients. And so there's a huge need for nurse practitioners and an increase in enrollment and opportunities for nurse practitioners in this province, absolutely. But that doesn't mean that there's also not a huge need for physician assistants. So the Conference Board of Canada actually had a nice report that looked at the fiscal benefit of physician assistants in our publicly funded healthcare system, and it resoundingly showed that there is huge fiscal benefit, especially if there's innovative funding models that are created, which is, I know there's some chat about funding models, and certainly I think Saskatchewan maybe has an opportunity to be innovative in this. But it's not just the fiscal benefit. Of course, fiscal is important, but it's also what's the benefit to the system, to the access to care, to providing, as Sarah had mentioned and yourself, Todd, right, access to care that people aren't receiving at all in some areas of our province. Tara had mentioned at the CAPA meeting that we had in Ottawa that having the physician assistants on board with Agamaswin now allowed 50% more health stations to be open before where there weren't physician assistants. So that's an example. But also physician benefit, right? Sarah nicely mentioned that this is an investment and there's an eventually return on investment. But what the studies have shown is that physician assistants also bring back the joy in the work for physicians and decrease physician burnout. So although, of course, it's for the patients, it also is helpful for us, many of us here who are physicians who do need help. We do need that assistance. And so that's where I think that the benefit is multifaceted.
Dr. Goulet, I see you still have your hand raised. Is there anything that you wanted to add?
Sure, I would just add related to this conversation that I would agree with Dr. Domes. Like, I think that there is more than enough work for all of us and in our healthcare systems that having both nurse practitioners and physician assistants would are needed, I'm sure, across both of our provinces. From my own experience, I've worked with nurse practitioners in a variety of different settings, and then obviously very closely with physician assistants. I'll echo what Dr. Domes just said. Like, I haven't had many experiences working with a nurse practitioner colleague, because we don't tend to work with each other because it's independent, it's like so independent practice. That there's not the same like reduction of workload or like team-based practice or like we got together with our physician assistants and said, let's try to increase care and how can we do this together, and as a team we decided that because we have the physician assistants we could do that. It like, I don't know that our nurse practitioner colleagues may have engaged in that because we sort of all see each other as doing the same job and working collectively to get the stuff that we need to get done. And so that for me, that relationship is quite a bit more different. And if I have to be honest, like sometimes because of our training, our nurse practitioner colleagues, at least the ones I've worked with, tend to, favor or be very robustly trained at comprehensive chronic care, and primary care, and that is absolutely needed. That maybe in our nursing station model is less helpful, and sometimes the nurse practitioners' work actually contradicts like our team of physicians' work, whereas that doesn't happen at all with our physician assistants because we talk to each other so much, and a physician assistant patterns their practice over what our physician team is already doing. So, and that is not at all like, thank goodness the nurse practitioners come here and work on the comprehensive like primary and chronic care, because oftentimes we can't get to that. But here in our work environment, and here in our work environment, sometimes they get pulled to be like nurses in primary care roles, and they can't even do they can't even use their skills as a nurse practitioner because we're so short-staffed. So one is not better or worse. I just think like there's absolutely enough work for us all to share in the load, and it would help to increase care.
Rizawa, sorry if that's not how you say your name.
You say right. So I'm
Oh,
Dr.
perfect.
Marova. I'm one of the family physician working in Regina, Saskatchewan. I have been working in teams since I started practice. I work in Regina Community Clinic for 24 years, and I work in the chronic non-cancer pain clinic for 5 years. Basically, wherever I go, I work with a team. I work with nurses, nurse practitioners, counselors, social workers, and I think the whole idea of the physician assistant will be fitting very well in that team. A while ago, our group of physicians in our clinic, they said the ministry is asking us and pushing us to try to use the physician assistant in our practice. I don't know. They said, so what should we do? Where we will put them? They were confused again between the role of the nurse practitioners that we have been working with them for a long time and the physician assistant. Interestingly and surprisingly, Canada is a small country because I don't know if Todd remembered me, but I remember Todd. When I started to listen to this conversation of today, I was in my car driving home. I was on call today. The minute I arrived home, I went directly on the link at my laptop. Then I saw Todd. I don't know if Todd will remember me. 2014, Todd was working. The minute he said, I work in the army and I work with so many experiences, I only knew a very kind, caring, smart person that I met in Winnipeg in 2014. Sorry, getting emotional. Then he was the physician assistant was in a rehab center. My dad has a major brain surgery, and he was sent there to recover. when he went there, I met this gentleman. He was very kind. And to be honest, I didn't know what a physician assistant's role are because we never had it in Saskatchewan. And I thought he's a physician responsible for that work because he was so caring, he's taking care of all the patients. And interestingly, he was smart in it because I told him my dad has this dripping from his nose. I don't think it is his allergies, it's thick. And he said, I'm afraid it would be his leaking from the spinal fluid. So he tested it in front of me, and voila, I don't know if you remember that. And yeah, and right now he said, yeah, he is leaking. The spinal fluid is leaking. We better contact the surgeon, neurosurgeon tomorrow morning. So I knew how important his role is there. So I know, as we said, anywhere they go, they do the major training, then they have to be customized with whatever team they are working, and they could fit perfectly there. And I don't doubt that. And I think I'm there to support wherever I can because I've been a faculty of College of Medicine since 2007. So I'm trained all the physician and resident and international graduate. I'm involved in the CPAC, program. So I think now when we do this discussion with our team at Regina Community Clinic, I can tell them, yeah, we can fit them properly in our team, and they'll be a great assets, I think. And I'm really excited. I didn't even know the whole conversation is about this, but I'm glad that I joined, and now I know what's going on, and it will be a good step. I do something very good for Saskatchewan to start the whole program, and I'm willing to help if anybody needs help in training and supervising and fitting the new addition to our team.
That's great. Thank you for that. Dr. Goulet.
And by the way, that person was Todd. Todd, do you remember me? Yeah.
That's awesome. I just noticed in the chat, there's a lot of conversation around the difference between clinical assistants, IMG docs, and physician assistants. So we also hire clinical assistants at Ongomiswin, and many of our physicians who work for us came through the IMG program. So they do not cross over any of those pathways. There's sort of no way to go between any of them. A clinical assistant is generally a physician who's trained in another country, who moves to Canada and goes through a variety of steps. Like I only know CPSM step. So Deborah, like you might want to jump in with what CPSS does, but generally they write the sort of the MCQE exams, and then they can write an exam in Manitoba to be licensed as a clinical assistant, which is sort of similar, or was similar, to an OSCE. And then they also require physician supervision. CPSM's regulations around that are entirely different than what is for a physician assistant. And then most of those clinical assistants are actually looking to get into a residency training path to become an independent physician. And train as a family doctor or whatever it is, whatever residency program that they get into. And we also have a shorter route called EMPLR that is a shorter residency training program for family physicians in Manitoba. So there's no crossover between a clinical assistant and a physician assistant. And the only way to become a physician assistant is to go through a physician assistant program. There isn't, if you weren't able to finish medical school, you can't be a physician assistant. And if you've come as an IMG to Canada, you also wouldn't be able to just cross over into those roles. They're three independent practitioners, essentially. The other thing I noticed, people were asking about prescriptions. So yes, our physician assistants can prescribe everything other than and this has to do with our federal practice. Generally, physician assistants can even prescribe narcotics and benzodiazepines, especially within hospital settings. So those who work in surgery departments or on wards in emergency departments are fully licensed and able to write orders for narcotics and benzos. They cannot write those prescriptions in Manitoba that would go to a pharmacy. So I need to step in if we have a palliative care patient in the community and I need to order the medication outside the hospital. they'll just ask me, like we have a whole different triplicate kind of prescribing pattern with CPSM, as I'm sure CPSS has something similar. And so that would be the only time that I would get involved and talk to the pharmacy and write the prescription for whichever the patient is. And I would review the case with the physician assistant who wants to prescribe that, and just make sure that I also agree that the narcotic or controlled substance is something that would be beneficial to the patient. Or I might call the patient in myself or go see them, just to make sure that I want, like, that we all agree that the prescription's something that's necessary. So hopefully that clarifies some of the conversation in the chat.
I was just going to comment on the question that Tori asked, and the public responds the same as anyone else. Usually there's no issues with a physician assistant coming to see the patient. We introduce ourselves as such. We do sit down and do the normal interview. We see the patient. I've had comments in the past that some of the public prefer, because the physician assistant may be able to spend an extra 2 minutes, 3 minutes, 5 minutes, where the doctor who's in a really busy clinic is not able to do that. So sometimes that is one of the benefits. As well, when you work for a service, sometimes you provide more of a continuity, especially when you work with a service that has residents. So they may not see the same resident each time, but they see the same PA every time, where the PA is coming in, they get to know that person. So it's you do build those relationships with patients. So a lot of times there's not much difference. People will say, "Oh, you're not the doctor," or you see them the next time, "Oh, doctor." No, I'm not the doctor. I'm the physician assistant. So making sure that we clarify our roles, but reception has been great in my 14 years that I've been doing this work. So.
And in our program, we have had 0 incidents of any patient ever asking to see a doctor instead of a physician assistant. In like the 5 years across multiple communities, not one patient has ever said, "I want to see the doctor." Like, they've all been extremely happy with the service. As Taz says, even more happy sometimes with the physician assistant's care than some of our physicians that we have.
There was a question. Sorry, go ahead,
Sorry.
Todd.
I'm just going through as the questions are coming up. So Kaylee's was about we would be registered with CPSS. So therefore we do work under a doctor's license, whether it be Manitoba, Saskatchewan, Ontario, Nova Scotia. It's very similar in all of the provinces under the colleges. Licensed to practice medicine in Saskatchewan. Deborah answered that one. And is there a time limit? No, really, we don't have a time limit. If I spend 5 minutes with a patient or I spend an hour with a patient, it's going to depend on what the patient's needs are. And then if I need to discuss after that. So. Major differences between PA and nurse practitioner scopes of practice. Once again, nurse practitioners are independent. They do practice independently. There are the biggest things that I've seen and I will clarify because it's the delegation of medical acts. If I'm working for a supervising physician, he can delegate to me any of his procedures that he can do. So, but sometimes I do believe that certain delegated acts can't be delegated to nurses unless they've been trained to do them. So, like doing a cystoscope, unless the nurse practitioner has specific training or takes a course in that, they wouldn't be able to do it. Whereas a physician can self-train a physician assistant to do those things, and as long as the supervising physician remains competent to do those things. So
There was also a question earlier that I don't know that we've addressed about liability. There was some concern about PAs practicing that if the supervising physician would be liable. So perhaps we can answer that from both your perspectives, Todd and Dr. Goulet.
Yeah, certainly. So I supervise like quite a number of our physician assistants, obviously, like every week. And I would say there have been some errors that I'm not errorless in my practice too. Sometimes I've by accident prescribed somebody who has a lower EGFR the wrong dose of a medication, for example. And had to go back and correct that. And luckily the pharmacy caught it. So we have had some issues with, I wouldn't say like the physician assistant practice, but just sort of everyday things that happens in practice and so I've thought a lot about this, and we talk about this as a physician group in terms of what's our liability. So physician assistants carry their own liability insurance. So it's sort of it's not like they're actually using my insurance. And as was already said by Deborah, I don't need to like increase my liability or insurance or change it in any way. I am like in every case that Todd sees, if I'm the physician who's here, like practicing with him, in every chart, he's going to write my name on every prescription and on every CT rec. So like I will sometimes get phone calls from radiology, urgent phone calls about, this, you ordered this on someone, and Tara might have ordered it. But they don't contact Tara, they'll contact me about the urgent case. But I also know where Tara practices. And so I'll phone and say, hey, did you order this urgent CT? And what's this case about? And oftentimes she'll say, this is what I'm going to do about it. And I will take care of it. And make sure that the patient gets the care that they need. But so in that way, I don't feel like I carry more risk than I do my practicing myself, but I am certainly tied to the work that Todd and Tara and our other physician assistants do. And should there be like a medical legal issue or a complaint to CPSM, I believe that like I will have to get involved in that in some way. And just like any other medical legal like proceedings, or like whenever we're sort of called into a case where there's a team of us who work together in the hospital and a patient had questions about their outcome, the responsibility and the team is always sort of like percentage based on the interactions that you had. So when Todd consults me after something happens, I can say I didn't have as much input in that. So despite the fact that I'm linked to the case, obviously, and I'm going to know about it. And Todd and I have worked together for years, and I would have done the same thing because I know Todd would call me if he had questions about what to do. It's like a graduated level of your comfort with having somebody like involve you with your license, but you're not totally disconnected from them, right? So that's kind of how I'll explain it. And I would not want to work with a physician assistant who I'd never met, who was working in a remote community, who I didn't know their pattern of practice, which is why we start with all of us working together and we go see the patients with them. And Todd, like we've graduated to this very significant level of independence, but over years. It's not something that I would ever like offer to do without developing that relationship and understanding that goes back and forth before you feel like you're at the level where you can really practice in an independent way.
Most of the College of Physicians and Surgeons of Manitoba requires myself, because I don't work under the union or Winnipeg Regional Health Authority, any of the health authorities, requires me to carry my own liability insurance, which is through BMS Group, and I have $10 million of liability insurance for working outside of the health authorities. So we are covered under our own, and thanks to CAPA, we have actually a really good coverage. So for PAs.
Okay, I see that we're nearing the end of our time here. Here's a really good question for you, Todd, that maybe we should consider closing on. What gives you joy in your work with the experience? Oh, there's more questions. I just lost it.
Uh-oh.
With the experience that you have, do you sometimes wish that you had gone to medical school instead of being a PA?
Some days and some days not. I'll be honest. There's some days I wonder. I enjoy listening to the stories. I enjoy seeing people. I enjoy seeing patients. I enjoy helping them. I enjoy procedural medicine, but all aspects. Those are the things that, bring me joy. One story I tell, when I first came to this community, I came into the office and I was seeing an 80-year-old Kukum who, the night before, I was up most of the night and my hair was standing straight up on end. So I picked up my hat and I put my hat on after I ate breakfast and I come back to work to see patients again. And this patient came in and she was telling me her story. And afterwards, after she told me her story, I said, I really have to apologize for wearing my hat. I usually don't do that. And so this lady looks at me across the table and she's like, no, you know what? I think it's pretty cool. You're the first doctor I've ever seen that's worn a hat when I went to see him. And it was those sorts of things and those comments from the community that it didn't matter how I looked, how I was dressed, nothing. I was there to help them. And that's some things, and hearing some of those stories and talking to some of the people that bring me joy. And it was the same sorts of things that brought me joy when I worked in urology, as well as in the military, hearing some of the stories of the patients and background and those sorts of things. So would I get that spending another 4 to 6 years becoming a doctor? Probably, but right now I don't know if I have the time to do that with everything that's going on. So I will mention about Kaylee's comment here. Manage call after hours. It's the same. As you build your scope of practice, you would go see the patient, do the consult, and depending on where your scope of practice lies, contact your supervising physician or initiate treatment, much the same as I do here. And then basically field after hours, if I needed to call my supervising physician, then there would always be somebody on with me that I could pick up the phone and say, this is what I've seen, this is what I've done. And sometimes you get, yeah, we'll maybe try this, or sometimes you get, I got nothing. There's
No,
not
and
much more you can
my
do.
question is
and you
more
kinda go from there.
geared towards like the like, just because the collective bargaining agreements are very strict about like when you can work and how you manage those after hours. So then you would, and I know the HSAS agreement is quite strict about that. So I'm just wondering if there's like a specific kind of workaround, or how will that work?
I would say that would probably come down to the agreement that the physician assistant signs. So with Winnipeg Regional Health Authority, they had 3 classifications. One was the 2080, which was Monday to Friday, 8 to 4. And then there was a 2240 and a 2600. So those positions, when they advertised them under PCAM, under the union, that's how many hours that they could work, which included call. So it would depend on the contract that somebody was offered from the health authority, those positions, and if it was written into that contract.
Might just be worth addressing Salma's question as well, just to clarify that a physician assistant program does not lead to residency. It is an entirely independent program on its own. That's a master's level program, and you don't then continue on into residency in the same way you would as graduating from an MD, like an undergraduate MD program. So completely different paths.
The specialty training, if you were hired, say for urology, your time in urology would be being trained by the urologists and those skills that they wanted you to perform. The same as general surgery or thoracics or any of the other specialists. They would train you on their own once they hired you.
So just as a reminder, this session has been recorded and will be made available shortly. And I believe we can also take all of the questions that were submitted in the chat. Maybe we can put together a Q&A as well that can be available for quick reference in the future. With that, are there any other last questions before we conclude for the evening?
I see Alexa has a
Oh,
question.
sorry, Alexa, I missed that.
No, it's all good. It's all good. I have a really quick question. Todd, you were saying that they're trained, like you're trained in the first 6 months, 1 year, whatever that is. So are you normally hired for like a 5-year contract or something, or no? Just you
No.
just
When
okay.
with Winnipeg Regional Health, it was you're hired into the contract, and then usually sadly there's a probation period when you go into work for a group of people, because if the relationship isn't going to work out, it's going to, you're going to know within the first few months that the doctor physician relationship or the physician assistant is not the right person for that position. It's a good news, bad news sort of thing, because the reporting period for CPSS is the way that supervisors can actually say this person is not a good fit for this position because of these reasons, and then it would go from there. So there's usually a probation period. And most times during the interview, most people know if they're going to be a good fit for a position, which is a good thing, or the personality is the right fit. So
Okay, yeah. Thank you. That makes sense. That probably is a little bit unfortunate if it doesn't work out in that initial run, but thank you.
That's wonderful. Well, thanks everyone for joining tonight, and yeah, we're really excited that we're launching this new profession and new program. Wanted to give a special thanks to all the presenters, especially Dr. Goulet and Todd for sharing your stories and your experiences. Have a good night.